Everyone now that's planning large studies in CLL likes to argue the long-term strategy, but what I think we can learn from this immediately is that this is an effective, very short-term strategy for reducing the amount of CLL. So the lymphocyte count after just 1 month of obinutuzumab, which I'll mention is dosed as per the US prescribing, so it's more dose dense over the first month of treatment, really reduces the lymphocyte count dramatically. So there was no one with an absolute lymphocyte count over the threshold of 25, which is for the prescribing, puts you in a medium or at least a medium risk group. And that actually when ibrutinib was started, generally you see a treatment-related lymphocytosis, so the lymphocyte count goes up. And we saw that happen, so there was a statistically significant increase in lymphocyte count, but it was nowhere near approaching the levels prior to receiving obinutuzumab. So what you can take away from this right away as someone in general practice, if it is important to put someone in a lower risk category to reduce tumor burden prior to starting venetoclax as a plan, especially in a practice environment where it might be less preferable to treat a high-risk patient or where people are unwilling or unable to be hospitalized for this. You know, it's a lot of healthcare expenditure, and people certainly don't like having to stay in the hospital to get venetoclax. In my personal experience, most of them don't prefer it. It's actually ideally a boring experience for them, but it's not fun. You know, you could use one of these strategies to give probably just obinutuzumab alone. You'd have to be very careful to make sure you repeat CT scans to ensure that lymph node bulk had decreased, but it could be used to try to downgrade tumor lysis risk and so that venetoclax could be started safely in settings that avoid hospital stays.